Subcommittee Appropriations meeting with Department of Rehab. Chris, you're free to go ahead and present.
All right. Thank you, Mr. Chairman. Good morning, everybody. What I've got before you today, this packet's a little thicker than normal. You know, with it being a new election cycle, I wasn't sure who was going to be here and the experience everyone has with our agency. So it's a little thicker than normal, but I'll be glad to go over anything y'all want to. I was going to kind of hit the high points to stay within the 30 minutes. So looking over on that first, or the second page, the Mississippi Department of Rehab Services is the state agency that has the responsibility of serving individuals with disabilities. We do it through 4 major programs. We do it through the Office of Vocational Rehab, also Vocational Rehab for the Blind, Disability Termination Services, and Special Disability Programs. We do it through 45 offices. We have about 1,000 employees. But again, everything we do is individualized. It's in order to help a person live more independently and also to help a person find employment. So looking over on that third page, that's your map. This shows you where our offices are. We have roughly 45 offices around the state. So we serve the entire state through these 45 offices, but that kind of gives you a glimpse of where we are and where our folks are. Flipping over to page 4 is our Office of Vocational Rehab and Office of Vocational Rehab for the Blind. So these are our first 2 programs we're going to talk about. And these are the programs where we help individuals, again, with disabilities, prepare for, obtain, maintain full-time employment. So the services we provide are strictly based on what the person needs and what their employment goal is. So, for example, Chairman Blackwell, you and I may have the same disability, but if we both have a different employment outcome, the services we both get are going to be totally different because everything is individualized. So when you look at the numbers, looking on letter C, we serve 14,000 to 18,000 Mississippians each year through this program. Looking at letter D, of that amount, 3,000 are the number of people we put back to work every year. So we say 3,000 taxpayers by helping those individuals reach their employment goal. Looking down on F, InSpark, which is through Mississippi State University, we asked them to do a return on investment study for us. And what they came back with is the ROI to the Mississippi taxpayer is 2.5. Basically, what that means is when we put a person back to work through our vocational programs, the state of Mississippi is going to see their dollar back plus another $1.50. So that is through state income tax. That's through reduction of public assistance. But again, it's showing that the program works. It's showing that the program more than pays for itself because every state dollar y'all give us through our vocational programs, once we put that person back to work, you're getting your dollar back plus another $1.50. Looking over on page 5, letter H talks about pre-employment transition services. We are actually in the schools. We are working with the schools. Through our federal regulations, we can serve young adults as young as 14 years old. So through our transition counselors, we are going into the schools, working with individuals to help them reach an employment goal once they get out of school. So when you look at what we call pre-ETs, there are 5 different categories. There you see on letter H. The first is job exploration counseling. So what we can do is we can sit down with the individual and say, basically, what do you want to do with the rest of your life? What career are you interested in? And we can help that individual make those decisions. Work-based learning. A young adult may say, the example I like to use is we had a young adult one time say, I want to go into childcare. I love kids. I love to be in that atmosphere. So through work-based learning, we were able to put that young adult into an internship. And 2 hours into it, she called her counselor and says, get me out of here. These kids are driving me crazy. But through work-based learning, she was able to actually see if that was her career choice. And ended up in that case, it wasn't. So we were able to go back to job exploration and help that individual find a career goal that they really liked. Post-secondary education, that's helping someone maybe go to college. Workplace readiness, getting that individual ready for work. And then self-advocacy, helping that person be able to speak about their disability and advocate for themselves. So again, that's through the schools. That's what we're doing, going into the schools around the state and really trying to reach these young adults. Looking on letter I, Project Search. This is something we're really excited about. About 5 years ago, I think it was, we brought Project Search into the state of Mississippi. It's a 9-month internship. It's a school internship where we partner with the school and we partner with an employer. And these young adults, instead of going to school in their last year of high school, they're actually going to the employer job site and they're working or they're doing 3 internships out of that 9-month stint and then hopefully getting ready for employment. Our success rate is about 80 to 90%. So other kids going through the Project Search are actually landing jobs, once they get out. To kind of tell you a story, we had one young adult has autism. He's on the spectrum. First day, he was nonverbal, kind of sat in the corner, didn't speak. But through that 9-month internship, we do a graduation at the end. And the work skills adjustment person had each young adult get up and speak in the podium. And do you know that young adult got behind that podium? I mean, he threw his arms out and he was like, "Good morning. Let me tell you what I learned at Project Search." So to really see where that young adult was day 1 and where he went day 90 was truly an awesome thing. So we really love Project Search. We love to see how these young adults' lives are affected. And I can tell you, when we go to these graduations in May, we have one for each site. The number of parents that come up to us and say, "Thank you for this program." Our young adults, when they got out of high school, they go home and watch TV till we got home from work. But through Project Search, they're gaining work skills. They're getting jobs at the end of this 9-month internship. So we really love Project Search, and we really like to see how it's truly changing lives. Looking over on page 6, internships. We continue to work hard with business on internships. We can actually pay the hourly wage through our federal regulations for someone to go through an internship. So, we feel that's a win-win. It's a win for the business. It's a win for our client to help them gain valuable work experience to get ready for the future. So we really like internships. Letter K, partners with employers. We are really working hard to not only find the small businesses, but land the large businesses. We've had a long-standing relationship with Sephora up in North Mississippi. We're currently working with Toyota to create a program there. We're trying to get a Project Search in Amazon, working on that. Milwaukee Tools, we have a Project Search site there, but really trying to find these large businesses like Sephora who committed to say, we want 30% of our workforce to be individuals with disabilities. So I think prior to COVID, I think we had 130 folks working for Sephora. Of course, it dropped after COVID, but I think we're up to about 100 to 110 individuals working for Sephora right now. Just a quick story. I know I got 30 minutes, so forgive me. But, in talking about Sephora, there's a gentleman there, and it's on the video that he's 52 years old, has an intellectual disability, was told his entire life, all you would ever do is clean toilets. You imagine that, telling someone growing up, all you're ever going to do is clean toilets because of your disability. But through the work of our counselors, through our partnership with Sephora, that gentleman was able to obtain a full-time job. He got full-time pay, full-time benefits, full benefits, and he was able to move out of his parents' house and into his own apartment. Because again, guys, these programs work. They truly change lives every day. Looking down on M, Structured Discovery, that's a new center. I believe I talked with y'all last year about that. So we have got the new center. It's fixing to start at the coast next month, I think it is. And it's just another way to train individuals who are blind or visually impaired. So Mississippi currently does not have a Structured Discovery Center. So what we were having to do is send clients to Louisiana, somewhere up north. I can't remember now where that is. But now through having the center, folks are able to stay at home to get this training as opposed to having to go to north, out of state. So that's the vocational side. Those are those 2 programs. Looking on page 7, these are our special disability programs. So basically what we do here is we operate 2 home and community-based waivers. So we do this through an interagency agreement with the Division of Medicaid. We roughly serve 3,800 to 4,000 Mississippians every year through this program. Basically what we're doing here is providing personal care attendant services. So PCA services, we're hiring the PCAs to go in the houses, take care of our clients, help with daily living, changing, food preparation, showering, just being able to live at home as opposed to a long-term care facility. So, roughly 4,000 Mississippians every year are receiving the service through y'all support. Yes, sir. Yes, sir. We do. Yes, sir. Yeah, the waiting list as of February 1st is 700 people. If you'll remember back when I became director, 2015, 2016, we were over 3,000. So we have been able to get that number down to 700. A lot of the slots we've been able to add through the years have been through attrition. Unfortunately, we lose about 200 to 300 individuals every year, and we were able to refill their position. So a lot of trying to get that number down has been the result of attrition. Trying to think. I'm not sure. I'm not sure how long. I'm trying to remember how old those referrals are. I think they're less than 6 months old. I think the oldest referral on that 700 is less than 6 months old, if I remember right. But I can get you that exact date. Oh, good question. Oh, I'm trying to remember. I just looked at that yesterday. Wait, is it 23? No, we've got 677 that are on the IL waiver and 23 that are on the traumatic brain injury waiver. Looking at letter F, y'all have helped us a lot trying to get the PCA rates up. Prior to COVID, we were paying personal care attendants $9.50 an hour. Once COVID happened and all salaries jumped up across the state, $9.50 was not enough to maintain our PCAs. So we did receive funding from y'all to up them to $10.50 an hour in 2023, and then we increased them to $11 an hour this current year, 2024. We've got another request to up them again, which Andy's going to talk about. But by being able to up those hourly wages, we've been able to, cut back on some of the turnover. Now we're still seeing some, of course, but we have been able to see a difference by paying $11 as opposed to $9.50 an hour. G talks about, in addition to personal care attendant services, we do a lot of home modifications, vehicle modifications, durable medical equipment. Again, whatever that person needs to live at home safely, we were able to do that. So, I'm sure y'all get a lot of calls maybe from constituents who are needing, rolling showers or widening doors or ramps or things like that. So we can actually do that for those individuals. Page 8, looking on H, I always like to report this number. Medicaid reports on their federal reports that it's $45,000 less expensive to serve someone on one of our waivers as opposed to institutional care. So if you just take 3,800 individuals times $45,000 per year, that's $171 million that we're saving the Medicaid program by having a person live at home in a home and community-based waiver as opposed to a long-term care facility. And then, like I mentioned earlier, we currently have 700 folks sitting on our waiting list. All right, so flipping over page 9, excuse me. This is our disability determination services. This is where we work with Social Security Administration to actually make the determinations for Social Security disability. So someone files in their Social Security regional office, those medical records are transmitted to us. We actually sit down and make those determinations on whether someone's eligible or not. 60 to 80,000 folks, file every year. The one thing I do want to point out to y'all is letter D. We are currently up to 304 days to make a decision. That's a long time compared to what it used to be. We were around 150 days roughly, but because of losing examiners, we have seen a backlog, and we've seen a backlog across the country. The Social Security reports that states are having trouble with this all across the country. So what we've done to try to keep our examiners is we have exercised the 10% in-range adjustments that y'all have allowed us, our personnel board has allowed us to do. We've given examiners 10% last year, and again this year. We've gotten the starting salary up to around $40,000, and we are actually seeing, maintaining people right now. We're not seeing the turnover we had been seeing. So between getting the salaries up and offering telework, we're able to maintain our staff. Unfortunately, Social Security is under a hiring freeze, so we're not able to hire examiners right now because of the budget issues in Congress. Basically, Social Security has said until they get an actual budget for the year, we're under a hiring freeze. So again, trying to get the salaries up, maintaining our examiners is extremely important because if one leaves, we don't have the ability to hire right now. So we're frozen on that. F, if you look down at F, it's something good to know. 235,000 Mississippians are receiving SSI, SSDI as of December. So that's about what, 10% of the population roughly are receiving a SSI or SSDI payment, and it's bringing in $235 million a month into the state of Mississippi. So that's a lot of money coming in funding our economy, and those are all decisions based on our examiners. So. Just a couple of things over on page 10. These are a few other things. We do the ABLE, Achieving a Better Life Experience. This is a savings account opportunity for individuals with disabilities. We administer that along with the state treasurer's office. The cool thing about this is earnings are federal income tax exempt. Contributions are deductible on your state income tax, and then account balances are exempt from asset tests. Medicaid says, I believe you can't have more than $2,000 in assets. I think that's right. The account balances in an enabled account don't go towards that. So that's a great opportunity for individuals to save for the future and not be concerned about, am I going to lose my benefits? So that's something we do. Prom, please return on Monday. That's something we do with the high schools. We go around to the high schools talking to kids about not drinking and driving, not texting and driving. It's a partnership with Highway Patrol. So we talk about the disability side of it. Unfortunately, Highway Patrol talks about the fatality side of it. And then we have an individual who has a disability that was affected by, a car accident. So to really be able to talk to those kids and try to get in their heads to make good decisions on, honestly, one of the probably most exciting, but one of the most deadly nights for a high school, student. So we do that. Benefit specialists, we have those as well. So we have specialists around the state who can sit down with a client and say, this is, if you make this much, this is what your benefits are going to look like. These are the credits you can obtain. These are the programs you can do. So really great opportunity, for these individuals to have someone sit down with them, go over their benefits and say, this is what you can do if you work or how long you work or things like that. So that's something else we offer that I did want to point out. So hopefully I didn't take up too much time, but those are the programs. I was going to have Andy talk about the budget stuff, and then I was going to follow up at the end with some personnel things. So, Andy.
All right. Mr. Howard, good morning, everyone. Appreciate your time. Go over the financial numbers, try to make this as quickly as possible as far as what we're requesting for 2025, starting on page 11. If you look at the top, this page is a snapshot of where we are with our state funding. Start top right there, you'll see 35.2 million. That's Elbow's base funding for 2025. That's also equal to the amount we received on our 2024 appropriation. That's made up of 31.6 million in general funds, 3.6 in healthcare expendable funds. What we're asking for in 2025 is an additional 1.6 in state funding. I'll go into the specifics in a little bit, but we're hoping that'll help us accomplish two different objectives. One is to meet the match on our Section 110 grant, $499,000. The second objective would be to allow us to increase our personal care attendant hourly wages by $1 from $11 per hour to $12 per hour. We estimate that would cost us $1.1 million. That additional 1.6 in state funding would bring our total state funding to 36.9 million for 2025. On page 12, we go into a little more detail about what those requests entail, starting with the first item. Traditionally, we have a Section 110 grant. That's the main source of funding for our vocational rehabilitation and our vocational rehabilitation for the blind program. And each year we receive traditionally about a 3% increase. We estimate that amount is going to be 1.8 million for the upcoming year. In order to utilize those funds, we would need to meet the match, the 21.3% match on those funds, which would equal $499,000. So in order to utilize that additional 1.8 million, we would need 499,000 in state funding just to meet the match and utilize those funds. The second request relates to our personal care attendants. Mr. Howard described, we're hoping to increase their wage. It's currently at $11 per hour. We're hoping to take it up to $12 per hour. These are non-state employees that are paid an hourly wage. They serve the clients that are on our home and community-based waiver program, doing, work, helping our clients live their daily lives, helping bathe the clients, dress them, use the restroom. It's challenging work. And I think what we're finding is, and it's probably, common to several other agencies as well, is that we're losing a lot of people as they're finding more lucrative opportunities and frankly, probably easier work for better pay. And so we're trying to stem the turnover we're experiencing. We're hoping that getting their wages up a little bit to $12 will certainly help. We estimate that would cost us a total of 1.1 million in state funding. That would be to meet the match that we would receive in other source funding through Medicaid and our partnership with them. Page 13 is just a snapshot in total of all sources of funding. You look on the left there, that's Elbow's base funding, 31.6 in general funds, 3.6 in healthcare expendable, 215 million in special funds. You see what we're requesting in state funding, 1.6 million that allow us to meet the match on 5.9 million worth of special funding for a total of 258 million in 2025. That's made up of 33.2 million in general funds, the healthcare expendable funds, and then 221.6 million in special funds. The last slide is a slide we like to always include. It just shows a snapshot of the percentage of state funding compared to the total for our agency that we spend on any given year. Basically for every dollar we spend as an agency to serve our clients, 14 cents of that is in state funding, 86 cents would be, in other source funding, federal or other. So, still a relatively low percentage, which is good. We try to tout that as best we can, so that we like to think that, we're a decent bang for the buck, so to speak. So that's all I've got for the financial portion. I'll turn it back over to Mr. Howard, who's got some information on our personnel and pen vacancies before he wraps it up.
Good deal. Thanks, Andy. So the last thing I've got is on page 15. This deals with our personnel needs. Currently, we have 945 filled pens. We have 184 vacancies for a total appropriated number for positions of 1,129. 123 of the 184 are currently on recruitment. So we're asking that those be, they're not cut is our request. 3 of those deal with the positions for the new blind center I mentioned earlier down on the coast. 23 are with our DDS program, which is 100% federal. But like I mentioned earlier, we're currently under a hiring freeze, so we can't hire those right now. But we're hoping once Social Security lifts that freeze, we can start hiring those again. So, I wasn't sure what our base number was in regards to pens, but I would like to request that the 184 that we're currently showing as vacant, that those be restored and that we be able to maintain the full 1,129 pens going into state fiscal year 2025. And then the last thing I had was there's another thing in your folder. It's kind of like the stay in the SIP plan. What we're requesting is the ability to be able to go into colleges as a recruitment tool and talk with individuals who are majoring in counseling and be able to pay for their junior and senior year in college with the agreement of them committing to 1 year of service for every semester we pay for. We feel like, if we go in and say a student takes advantage of it and we provide the full junior, senior year, then they would have to commit to us basically 4 years of state service, being a counselor or an examiner. We hope this will be a good way to recruit and maintain our staff. Just to be honest with you, back when I started in state government, when you'd pull a list of eligibles, it'd be 8 or 10 pages long. Now we pull a list of eligibles, you're lucky to get 1 full page. We've had situations before where we've had in one part of the state, we had interviews scheduled for the entire day. our HR folks got down there and no one showed up. So I'll tell you, it's hard to find, individuals who are looking for a state career. I mean, that's what we're experiencing. I'm sure other states are too, or state agencies are too. So we're hoping that through this internship opportunity, that we can go into the colleges, recruit the young talent, and really find people who have the heart to serve people with disabilities and have the knowledge to be able to do it well. So we're asking that we have a general bill to allow us to do it, and then an appropriation bill that would give us $200,000 worth of authority. I'm not asking for additional money, just to be able to use the funds that are within our section 1 and 2 of our appropriation bill to be able to fund this internship program. Again, we think it's a great way to recruit individuals from college to be counselors. So, yes, sir. Again, to be honest with you, we're mainly doing it through attrition. I know we have gotten in the past, y'all have given us funding for additional slots, which we've taken advantage of. But unfortunately, we lose about 200 to 300 individuals every year, and we're able to address the waiting list through attrition.
Mr. Chairman, Director, are you drawing down, are we giving you enough money to draw down all the federal dollars that would be available?
Yes, sir.
In every category?
Yeah. So through our vocational programs, through vocational rehab and vocational rehab for the blind, the state match is 21.3%. So we are receiving enough money to be able to match and draw down all those federal funds. On the home and community-based waiver side, we are subject to the Medicaid match. And yes, sir, we do have enough funding to make that match as well.
So the only other way that your waiting list could be addressed would be through additional general fund.
Yes, sir. Well, yeah, either through attrition or through new slots. Yes, sir. Those would be the two ways to address the waiting list. But the reason we didn't ask for new slots this year is because traditionally a counselor can handle a caseload of about 50 to 60 individuals. So if we were we're to the point now, I feel like if we were to add new slots, I'd probably need to come back and ask for additional counselors as well, because they're pretty much maxed out at their 50 to 60 in a caseload. And the reason I say that is because they're required to do monthly contacts, quarterly home visits, as well as, oversee the PCA. So there's a lot of work that needs to be done by the counselor for each client. And again, roughly a caseload of 50 to 60 is where we see those counselors serving on the home and community-based waivers.
Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. I heard you mention that you would like to see an increase, hourly increase from $11 to $12 to improve your retention rate.
Yes.
I guess my question would be, are the individual, the employees, are they receiving any type of health benefits?
You talking about like federal benefits? I'm not sure. Yeah, we wouldn't know that because we hire the personal care attendants, on an hourly wage. So we don't verify if they're receiving any kind of benefit. So I'm not sure. I'm not sure about that. Yeah, yeah. I mean, we can offer them health insurance through the Affordable Care Act, but if they're receiving any kind of federal benefits, I'm not sure about that. Mm-hmm. Yes, sir. Oh, yeah.
That was not
Yeah.
included in our base funding level for this year.
Yeah, we made that transfer first of the year. So I think it was July, sometime in July when the appropriation bill, came out, of course. We transferred that money to MIB. And I think it was through capital expense money, wasn't it? I think it was. Yeah. Yeah. So yes, sir. We made that transfer first of the year to them. So that's all been transferred out. Yes, sir. Yeah. Thank you. Sir? Yeah, yeah, we oversee the deaf program as well. Yeah, we have the Office of Deaf and Hard of Hearing as well as we have interpreters around the state.
Not necessarily for the rep, but I just want to, we got a young lady on.
Thank you.
Good to be here. Look, good morning, everybody. Drew Snyder, Executive Director of the Division Medicaid. Wanted to start out with a high-level look at where we've been and where we're going from a financial standpoint. State fiscal years 2019 to 2024, it was a long summer. It was the best fiscal condition in Medicaid's history. We had a record surplus despite record enrollment, no state support deficit in 6 consecutive years. If that has happened at any point, it hasn't happened this century. A lot of credit, a lot of factors in play there. But one thing that we would also say is that the legislature has been very supportive of the Medicaid program from a financial standpoint. We appreciate that. For this state fiscal year, we are requesting an increase in federal spending authority. driven primarily due to the MHAP changes. And we're also asking to use a little bit of additional special funds from the medical care fund to cover that non-federal share that doesn't have a state support impact. For fiscal year 2025, after getting the December numbers, we are projecting an increase need of 83 million in state support to avoid a state support deficit in state fiscal year 2025. We look at, we basically come up with 3 requests in a given year. We have the initial request that comes out in August. The numbers are updated around December and January, and then by March, we should have a new number. So this number may change a little bit. It went up over August in part, and I can talk about that a little bit later, but it's largely because some of the regular FMAP that was projected was a little bit lower than expected, and utilization was a little bit higher than expected. Fiscal year 26 beyond, we're going to spend down the cash balance in fiscal year 24 and 25. And so we are expecting a dramatic increase in state support in fiscal year 2026. I do 1.449 billion. So, and I'll talk about that a little bit later, but with the declining federal funding share and the federal regulatory landscape, some of the moves to kind of loosen utilization management practices and just the rising costs of care and labor, the Medicaid program is going to cost substantially more to fund in the future with potentially fewer levers to control those costs. But I do think, despite these demands, success is possible. I think it's going to be, as I say here, a delicate balancing act, but we can maintain positive momentum, while also minimizing the spillover effects, the impact to the healthcare delivery system, and making sure that we control costs for taxpayers. But it is going to require a prudent, thoughtful, measured approach to spending more in some places, finding some ways to curb spending in others, and just Medicaid is there's never one silver bullet in Medicaid. It's hundreds of decisions that end up making these big impacts. 2023 was a very good year for the Medicaid program. I think maybe what jumps out the most for people is that the hospital industry gained an additional $600 million in Medicaid funding when CMS approved the largest component of the hospital payment reform spending plan that'll reimburse managed care services at or near the commercial rate. I appreciate the support that the legislature has given, the leadership of Lieutenant Governor Hoseman and his team, and pushing us along. And just we had some we ran into some walls, but we were able to regroup and get this over the finish line and really get approval maybe a little bit sooner than we expected. So big impact for the hospitals without having a big impact on the state support spending. The permanent 12-month postpartum coverage for pregnant women went into effect earlier this year. And look, unwinding of the continuous enrollment, huge undertaking, really unprecedented for states. I think there was, I think people were, there was a lot of fearfulness that, that the Medicaid program was going to be really, really aggressive and kick off individuals unnecessarily. And, in looking at this, we tried to take a balanced approach. So, we wanted to make sure that redeterminations were accurate. So people that were eligible and had, taken those steps to retain eligibility, they maintain eligibility, we minimize the number of eligible folks that fell through the cracks, while also promptly disenrolling, those folks that don't meet Medicaid eligibility requirements. And I think it's the kind of thing that doesn't really make anybody happy, but I thought we've taken a tough situation and look, it's been far from perfect. But we're well over halfway there, and there is, it has consumed a lot of attention and resources, but it is moving forward. We eliminated member copays. That was some flexibility that had been given through the legislature a few years prior. And I think there were some meager cost sharing requirements, and we'll see. I think it was a good year for customer experience for members, where we were really focused on removing some unnecessary barriers. And you can see that we released the self-service portal in October that will allow members to go online with some additional functionality they didn't have previously, where an easier process to change renewal information, and really we started texting and emailing members about renewals, and really just trying to make that user experience better than it's been before. Not to say there's still a lot of work to be done, but we're moving in the right direction. Certain anti-obesity drugs have been added to our preferred drug list, the request the Pharmacy and Therapeutics Committee. We don't have bariatric, so this will be a new test, and I think we're real focused from a clinical standpoint on what we call the 3 M's: maternal, mental, metabolic, and I think it's been well received so far, but I don't think we've seen overwhelming utilization or really a huge cost to taxpayers. We actually received the best score in the country in the percentage of women who have a delivery, who have a timely postpartum care visit. Probably haven't heard about that, but credit to our provider community and also to our MCOs on that. The ambulance UPL and directed payment program that the legislature put into effect, that's been implemented. Big impact for our ambulance providers. Reimbursement continues to go up. Some of that's based on cost. For rural health clinics, based on Medicare, the MEI, the Medicare economic index, made some adjustments for community mental health centers, dental, the 5% dental increases that the legislature put in. So a lot of provider we've seen some upward adjustments on reimbursement. In May, hospitals received a $137 million one-time payment through emergency authority that we got in before the PHE officially ended. We've onboarded a new utilization management quality improvement vendor, Intelligent, and that seems to be going pretty well. Silence sometimes the best indicator of success is silence, and it seems to we seem to be having a pretty successful transition there. And that one's noteworthy because it was a pretty large procurement and didn't actually get protested. And since in the last 4 or 5 years, the vendor protests have become really a common, just sort of a common business practice with respect to Medicaid procurements. We also continue to build the quality of our team. That's at senior level as well with the frontline workers, and I think, yeah, long-term, the agency's gonna have to continue, the skill sets are gonna have to continue to change, but we're taking some good steps, I think, in the right direction to build a strong, modern, Medicaid program that that can handle that is adaptable to change and can handle, a lot, this kind of intersection between clinical operations, finance, and, and just general government administration. So. Just quickly on the hospital, the add-on payments, the hospitals, we paid out 800 and it had been pretty steady from 17 to 21 in that 750 to 765 range. 22 saw that increase in 23 due to the one-time payments. And then the MHAP, one component added about another 900 million. Dish was going to get a little smaller, but at the end of the day, like, it's a pretty, it is a substantial, really transformational impact, on the hospital industry, and will hopefully help preserve access across the state. And again, one thing I would note on that, very minimal impact on the non-federal share, on the state support of the non-federal share. So the Medicaid budget broken into a lot, it has in Medicaid spending, a lot of different components. The big part is the federal share, driven largely by what the federal medical assistance percentage is. That federal medical assistance percentage has been steadily dropping, and will continue to, the big drop really has happened over calendar year 2023, but we're going to continue to see small decreases in the federal share. This goes into some of the different components that not everything is matched at the FMAP. The general administrative activities are 50%, although some, if you meet certain conditions, are higher. The non-federal shares separated into a number of components: general fund revenue, the healthcare expendable fund, or the state support funding. Those two buckets is what we focus on a lot, and what I refer to as the state support funding. The other components of the non-federal share come from other state agencies. For instance, Department of Mental Health provides the non-federal share of some of the services that they administer. We also see healthcare related taxes providing a big part of the non-federal share. So probably for the last 14 to 15 years, hospitals have been assessed a bed tax that hasn't gotten over 104 million, but that amount goes to support the non-general Medicaid expenses. And they also put up the non-federal share for the directed payments that they get. So while they're putting up, they're paying taxes, the net benefit is astronomically higher for most than what they put in. There are some conditions at the federal level to be able to do this. We can't go over 6% of net patient revenue, and that we can't guarantee that every hospital would benefit from some sort of tax program. The carry forward is one component of spending. This year, we peaked out at about a cash balance of about 682 million, and probably will be using about 320 of that this year. I mentioned the drug rebates. We pay a base price for pharmaceuticals, but the pharmaceutical manufacturers do have a rebate program that ends up reducing the overall cost of some of those drugs, and that lowers the non-federal share expense. Look at the appropriation breakdown. $846 million for general funds. The medical care fund is at 352. We are going to be requesting an upward revision on that. Healthcare expendable fund is been consistent around 63.2 million. And then the special source funds, which are both those first three buckets are all non-federal share. And then the special source funds, which is the federal grant funds and some non-federal share. We are going to be asking for an upward adjustment to that to be able to take advantage of to have the authority to disperse those federal funds for medical services through the end of the fiscal year. So total Medicaid spending, as you can see, has gone up quite a bit in the past 20 years. We have seen some pretty significant upward movement between 2023 and 2024. That is predominantly driven by those additional payments to the hospitals, and that some of this does seem to be pretty consistent with what we're taking that out. Other spending does seem to be pretty consistent with some of the spending growth that we saw around COVID. We actually saw some drops early on because despite the enrollment was going up, but utilization was going down because a lot of people were just not going to the doctor during COVID, and there were a lot of elective procedures that were foregone. Utilization starting to tick back up, started in 2022 and continues to go up, starting to get us back to pre-pandemic levels. With some of the enrollment is going down, but some of our more high dollar members, your SSI population, and then those institutional long-term care members, that's going to stay pretty steady, and we might actually see a increasing demand there over time. While overall spending has been going up, state support spending has been flat, has actually dropped $100 million from the 2016 peak. This is really this is a pretty incredible number. And unfortunately, it's probably not one that we're going to see again for a very long time. And why is that? So the main reason that I want to touch on is a lot of factors in play. These are not necessarily the reason what this first one is, but there are a lot of spending factors in play. I'm not going to talk about every one of them, but I do want to address the declining federal share for medical expenses, the carry forward. There's the Medicare Part D expenses are going way up. That's a $17 million increase alone in state support funding. So that's a pretty home and community-based services. Those unit costs are going up. We're adding new members. I think there's a lot of enthusiasm, I think, about the growth there, but there are also cost considerations. But what I really want to hit on is what's happening here is the change in the non-federal share. So between 2023 and 2025, we're paying 42% more. The state is taking on 42% more to get the same level for the. So essentially, for every $1 spent on Medicaid, the state was having to put up 16 cents in 2023, and by fiscal year 2025, that goes up to 23. So a pretty dramatic change there. And the big part of that was during the public health emergency. As a condition of continuous enrollment, states were given a 6.2 percentage point increase in the regular FMAP. So we went from 77, 78 to 83, 84. So that 6.2 went away, but we've also seen the regular FMAP dropping in consecutive years. Some of that may be driven by like positive economic factors, but this is where a lot of the change that we're seeing in spending is really going to be focused. What we're doing to mitigate that from in the near term is the spend down of the cash balance. We peaked at 682, at the end of state fiscal year 2023. We're going to use, we're going to be down about 360 at the end of this year. Then we're going to use up the remaining cushion in fiscal year 2025. Enrollment is an X factor. So we added about 190,000 members from the beginning of the pandemic until June 2023. Since the unwinding began, we're down over 100. We expect to see some additional disenrollments over the next several months. We don't expect it to get lower than it was prior to COVID. I think we do expect to get down to at least 765,000 probably, but some of that is going to be variable. It may go down a little bit more than that, then rebound as some members are reinstated. But I think the number is going to be a little higher. In part because I think we do have a system now that I think makes it a little easier for folks who are eligible to stay eligible. And then there've been some other rules that have, and approaches that have been put in at the federal level that really that add some, make it a little harder to put in a few more steps and protections for disenrollment. So we're going to continue to monitor that. I think by mid-year we should have a better sense of where that number is going to be going forward. For state fiscal year 2025, we're right now in a place where we're asking for about a 9% increase in state support. That number will be updated again in March. I'm not sure how much it'll change, but we should see a little bit of movement. So your last slide. So what does this look like in state fiscal year 26? It's a big figure. We got to that based on the non-federal share, taking out the non-state support, non-federal share, and trending forward using the Medicare Economic Index of 4.6%. So big number ahead.
Thank you, Drew, for this report. Before I begin any questions, I want to compliment you and your staff for the administrative changes that you've made during the course of the year to improve the program. So you've done an excellent job there. There has been talk this session about Medicaid expansion. In the states that have done this, they've usually missed their mark on enrollees. I know we're down to about the 800,000 now. Projections are if we were to expand, we'd add probably another 200,000. If in keeping with other states, that's probably more likely going to be 400,000 to 500,000 people. Can you tell us what it's going to do to your budget if the state were to move in that direction?
I don't have an exact number. I think we've looked at some gross costs that were in the that were between 200 and 250 million a year. You know, that gross cost may be mitigated a little bit by insurance premium tax and some things that Medicaid may not directly see. But it's a pretty significant impact, and it's not, if it was, let's say it's 230, it won't probably there's a ramp up time. So year one, maybe it's not 230 million if it gets there. And then over time, that number is going to go up. I mean, you saw how the healthcare costs have been trending. So 230 can become 300 pretty quickly. The one thing that we do know about Medicaid expansion projections is that they've all been proven wrong. So we don't necessarily, I can't say in 2031 the expansion population is going to cost X, but it would be a significant cost driver over time. And particularly given that the we also have costs that we have to consider for our children, our pregnant moms, our low-income seniors, the waiver program, a lot of demands from that, that traditional needy population that's been the foundation of the Medicaid program, or was for the first 50 years.
Director, just want to ask you a couple of questions about page 3. And I see where it says, regarding the 600 million, it says after CMS approves, have they approved it?
There were two components, and the largest component is the one that they've approved. That was the changes to the hospital payments in managed care, and that's where I get the 600 number. The net impact is going to be a little higher than that, but we haven't gotten approval yet on the second component, although I do expect that we will soon.
So how much is it that they have approved?
About 80% of the total, I would think.
In the same regard in number 10, so the hospital received, have they received that 137 million?
Yeah, they have. We got that money out the door in May.
Okay. And could we get a breakout regarding? Okay. Thank you, Mr. Chairman. Thank you, Mr. Snyder.
Thank you, Mr. Chairman. Drew, again, thanks for your work and your team's work. A few questions. Let me go back to what Senator Blackwell, the chair, was asking about regarding the additional costs, and that's based on some projected number of additional enrollees. When you look at, of course, the most daunting thing for me as the appropriations chair is when you look at out years. And we knew this day was coming, but I didn't realize it was going to be at that sharp of an increase. The numbers you just gave him, is that factoring in, or is that an additional 250 million on top of this? Or do you think this would, based on projections, that amount would be flattened some to be maybe equal or lesser amount of an increase?
You're talking about with expansion?
26 or 27, yes, on the expansion issue.
Well, there's the sweetener, the 5%. There's that 5% increase in the regular FMAP. If you expand, you still have to take on the expansion cost. I've heard different numbers on that. Let's say it's 200 to 300 million in those years. I think you would probably see, you would see a little bit lower in those 26, 27, Then in 28, you're going to see an exponentially larger number, kind of expansion. When I think about that, it's kind of okay, you may get 600 million up front, but if you're paying around 230 million over 10 years, I don't know, do the math on that. I mean, the cost, in non-federal shares is going to go up.
Is going to go up with expansion. It on top of the number that you've got here.
That's correct.
And this year, I think 83 million is what you're requesting in addition to, above what we did last year. Is that right?
That's right.
We go back to something. I'm sorry I walked in late. You may have covered this, but on page 2 of your handout, down near the bottom, it says, with declining federal funding percentage, new federal policies on eligibility. Which federal policies on eligibility are we specifically referencing?
Some of that is what we're feeling now. I think that CMS took a different approach on unwinding. That I think there was one expectation that we were going to get a bit of a head start on doing renewals. And then at that point, we would, when it started, you'd be able to take action a little bit sooner. They made a decision that you've got to, until unwinding begins, you can't, like if there's a 22-year-old in a child category that ends at 19, you've got to go through the full process. That slows things down a little bit. There's some proposed eligibility rules that, we anticipate will require our workforce to take additional steps before removing individuals who move out of state or are unable to be located. And I think there's been a lot of attention that's been put on keeping people on the rolls who may not be eligible, while really, but that creates downstream impacts on application processing time for people who are eligible. So some of these rules haven't been finalized. The approach on unwinding certainly has, but some of the regulatory changes that have been proposed, I think, we should see final rules in mid-2024.
I tell you what, if you could just give me a breakdown and give it to the chair and Corbin too, if you don't mind, the breakdown of those policies, just so I understand all the policies that are affecting what you do. And the next one, potential utilization management restrictions. I have no idea what that means, but I would like to know what we're talking about.
Well, yeah, I know there's some legislation that's going out right now, and that would we would basically be spending tens of thousands of dollars more to just send out notices, written notices through the mail, informing people that there's been a PA change. So right now, when we change a preferred drug list, we post that a number of days in advance. It's online. The cost of that is zero. So there's some, not necessarily just some administrative components around the work that goes into that. And I think also from a user experience, I think there's some genuine interest in trying to not put in barriers that are unnecessary. There may be a cost to that, but it may be in a lot of cases, it's a reasonable cost. So finding a balance there is important, but I do think there are levers that may have been in the 2010s, maybe utilized a little more widely, that won't be available. And CMS is also, is putting in some changes around some of the authorization and utilization management processes.
Yeah, I tell you what, I'm realizing that we got to go in just a moment, but I've got probably a few more questions, but if you just get that information on those 2 points, for sure, get that to Chairman Blackwell and to Corbin as well. And we can talk, maybe we can set up a meeting later on. One final question, then I'll just jump too quickly. I forgot to ask on the analysis of the additional costs. Are you factoring that at basically the 802,000 number, or are you factoring that at the 760 number, or are you back on before re-enrollment started? Are you factoring those numbers at a higher number of enrollees?
Great question. I think 766,000.
Y'all factored that at 766, so you did take it down when you hoping you're going to tell me 800 or 900 to make me feel better.
Well, I'm
but
hoping the number is going to get better too.
get better, lower.
Lower, yeah.
Okay. Thank you, Mr. Chairman.
Yes. Look, you probably need to look at some ways to disincentivize this protest process that's really just become a business strategy for people to, draw out the process. And in a lot of cases, there's some real financial impacts there. I think some clarity around some, existing processes probably needs to be put in. And I think there's some things that are in the Public Records Act that relate to procurement that may be better and, addressed specifically in the procurement context. But that's something that we'd be, glad to get you, love to talk to you further about.